Hi, this is Francisco Ponce, and these are some things you'll need to know before proceeding with surgery with me. Uh, First of all, I start this first slide just saying that I do this operation with my patients under general anesthesia. This is known as a sleep DBS, and I've not been doing this on patient with the patients awake for quite some time now. If you do a YouTube search on deep brain stimulation, you may see videos of patients playing the violin, doing tasks awake in the operating room while the surgeon has a probe in the brain as the surgeon looks for the right spot. That's not how I perform the operation. I use preoperative imaging. I pick a target, and then I use an intraoperative CT scanner to verify that the electrode is within 2 millimeters of where I intended to place it. So you will not be awake for the operation. With me, you sign up to undergo the operation under anesthesia using this technique where we rely upon preoperative imaging and intraoperative imaging instead. So that being said, when we talk about benefits and indications, most commonly I'm using this to treat Parkinson's disease and essential tremor. For other indications, we can talk about that separately in person. But with Parkinson's, the narrative has become pretty clear over the years. The FDA, based upon the data, recognizes that deep brain stimulation improves quality of life for patients. And this is kind of an overview of how that's done. So this is a patient diary. So at the top, you have 7 a.m., 8 a.m., 9 a.m., midnight. At the bottom, you see the patients mark when they have breakfast, lunch, and dinner. And they document their medications. So they're taking medication 4 times a day. Cinnamon, Maripix, and Ativan. You can see the 4 timestamps. And the on state here is where the patient is when their medications are working. So that's called the on medication state. And then below here, you see the off state. That's the off medication state. And typically, when you come for deep brain stimulation, you'll have undergone what we call on-off testing. And that's when a neurologist or a physical therapist has you come in off your medications, not having taken them overnight. They do a series of standardized tests to evaluate your Parkinson's severity. They quantify that you get a score, and then you take your medication, and 30 minutes or so later, they redo all those tests, and they rescore you. And that gap between how good you are with medication and how bad you are without medication gives us a numerical value for the medication responsiveness that you demonstrate. So what this diary shows is very important in terms of understanding what to expect from DBS. And my experience has been that the more insight a patient has in their condition, and often that's informed by what the neurologist has told them, what education seminars have told them, the more insight they have in their medication responsiveness, the more satisfied they'll be from surgery because they know what they're signing up for and they don't have unrealistic expectations. So what this slide shows is when a patient is in their on state or versus their off state. So in this example, a patient wakes up in the morning, they take their pill, and it takes about an hour between 8 and 9 for them to ramp up into that on state. But however, they only last in the on state for about an hour before the effects wear off. So that's the wearing off. And then they're in this off state for about 2 hours, during which time they have lunch, they take their pills, and then they come back in an on state. So this basically illustrates the roller coaster experience that patients have who have done well with medications initially, but are advancing in their Parkinson's disease. So over time, we are aware that these fluctuations in symptoms happen. If you take a step back and you think about what our expectations are with medication, say, for example, diabetes, right? If somebody has diabetes, they expect to be on a regimen prescribed by their doctor that controls their blood sugar all day long. Same thing with blood pressure. Blood pressure problems, you take some pills, whatever, they may adjust the medications to optimize blood pressure control, but ultimately you're expecting to have your blood pressure controlled all day. Same thing with allergies, right? We know, we discovered that we saw this in the 70s, that people initially had done very well with Parkinson's medications, started developing these fluctuations. And that may be because of the mechanism by which medication is absorbed into the gut, the mechanism by which it's transported to the brain. Nonetheless, the effect of the medication in the brain has different effects over time. And so this is called motor fluctuations, wearing off. It's, again, the ups and downs that patients experience. And as they experience this, neurologists start to troubleshoot. They start to adjust the medication. So they may add the number of times a patient takes the medication each day. So I have patients taking medications 7 times a day, for example. So that's the journey of Parkinson's. Another occurrence is the development of dyskinesias. So dyskinesias are kind of squirmy movements that patients demonstrate that are a side effect of medication. So patients who are responding well to Parkinson's medication may start developing these dyskinesias. And that may also motivate the neurologist to adjust how often the medication is being taken and how much medication is being taken. So they may reduce the dose, but have the patient take it more times a day. So dyskinesias, these kind of squirmy movements, many patients actually prefer that feeling to the stiff and rigid feelings that they have off medication. So they'd rather be squirming, kind of a hyperactive state, than the underactive state of rigidity and bradykinesia. So that's kind of home base here. Is patients who do well with this therapy have done well with medications, but now they're developing motor fluctuations and dyskinesias. So looking at this slide, and some of my best patients will look at the slide, and while I'm talking about this, they'll nod, they'll be like, yeah, that's me in this diary. And so that's where insight comes in. So because what we're trying to accomplish with DBS is, in effect, capture that best response people have to medication and stabilize it. So many studies have been done on DBS, and one of the consistent findings is more of this on time. In addition, it helps reduce and sometimes even eliminate the dyskinesias, the squirmy side effects of medication. So capture that best response to medication, capture it and maintain it. So more of this on time without troublesome dyskinesias is kind of home base for what we're expecting with deep brain stimulation surgery. Again, this is kind of what we're expecting. With some patients will have tremors. These are kind of the exceptions to this rule. We do have patients who have tremors that don't respond well to medication, and we do find that deep brain stimulation controls the tremor better than the medications do. We also have some patients who just don't tolerate medication. No matter what, they're getting nauseated, they feel dizzy, their blood pressure goes down, and those would be a separate kind of category of patient that may consider DBS in order to reduce the medication requirements. Because one of the benefits, in addition to what's illustrated here, is that oftentimes the neurologist is able to reduce the medication quite significantly once DBS is initiated. So these are different MRIs, and these all illustrate different nodes within the electrical circuits in the brain. So over here we have the subthalamic nucleus, STN. That red dot is where I would target. The globus pallidus interna, GPI. The arrow shows where I would target here. VIM is a target we use for essential tremor, and the red dot shows where I would target. And ANT is actually the target for epilepsy, the anterior nucleus. And this red dot shows where I would target here. So basically, the evolution over the past 30 years of deep brain stimulation being performed is one whereby we've developed a better understanding of the imaging and the relationship between where an electrode is placed based upon imaging and how well a patient does. And it was this kind of confidence in the imaging that resulted in a consideration of doing this operation under general anesthesia. Now, keep in mind, the origins of the surgical technique back in the 1980s were not for deep brain stimulation. We borrowed the technique from ablations, meaning that instead of putting an electrode in the brain, neurosurgeons would actually cook the brain. They would actually heat up the brain until cells started to die, and they'd make an ablation, a lesion within the brain. And before you make that lesion, you'd have to check, double check, triple check, really make sure that that's the right spot, because you cannot undo the lesion. You can't undo a stroke. And so this ability to do operations on awake patients to verify that the correct location was acquired was really developed, refined in the 1980s, continued in the 1990s. And that was what was borrowed when deep brain stimulation started. And deep brain stimulation also developed before we had as good of an understanding of where the sweet spots are in these circuits, as well as before we had the resolution, the quality of MRI images that we see in these slides. So one useful way to think about deep brain stimulation, I'm a surgeon. I do operations, I operate. And I think it's useful to kind of think of deep brain stimulation rather than as a surgical treatment for Parkinson's or essential tremor, as an electrical treatment, an electrical therapy. And just like your neurologist will titrate medication doses, the neurologist will also titrate the electrical doses. They are managing that pacemaker. So my role in your care is to implant this therapy in a way that's safe and that's accurate. So safety, getting you in and out, back in the game, safe and sound, and placing the electrode in the appropriate target so that when the neurologist turns it on, the symptoms are controlled as expected. So the steps I take in surgery are to ensure your safety and to optimize the chances that I place the electrode in an efficacious area of the brain. If it's in the wrong spot, you expect your tremor to stop. The device is turned on, you get a bunch of side effects, the tremor doesn't stop. That's a good indication that it may not be optimally placed. So I do the best I can to ensure your safety and to maximize the precision and the accuracy of the lead placement. And the steps I do to take that do not require you to be awake. And that's why we call this a sleep DBS, meaning that you can be under anesthesia while I do this. I do this at two hospitals, St. Joseph's Hospital and Medical Center. That's the renowned Barrow Neurological Institute. We have patients come from all over, and that's where I trained. That's a teaching environment, so I have residents that work with me, and residents actually rotate with me for 3 months at a time during their second year. So I've standardized the steps of this operation, and I teach these steps to the residents, and there are portions that they learn to perform independently. For example, placing the frame, the stereotactic frame, making holes, planning the incisions, making the incisions. So I'll always be there for the critical parts of the operation, but there are portions of the operation that once they're trained sufficiently, they can perform unsupervised, but I'm always immediately available. Concurrent rooms is a practice I don't do too often, but that basically, it's better phrase is overlapping rooms. And that's basically where, for efficiency's sake, I'll run 2 operating rooms. And for example, while one room is closing, we'll start another operation in the room next door. And you can see my disclosures video insofar as kind of what that implies and what that means. But you'll meet the resident before surgery. They'll put the mark on you. And it's important that you're aware of their role in your care. I think overall it improves the quality and the experience of the hospitalization. I also operate at Scottsdale Osborne. I take trauma call. I do brain traumas and spine operations there, and that is a non-teaching facility. And I've been working out there for years. It's kind of off campus. My clinic is at St. Joseph's Hospital, and Scottsdale is about 25 minutes away. So I operate there on Mondays at this time. And if you look good the morning after, the physician's assistants or nurse practitioners will discharge you. But I'm not after the operation. The rest of the week I'm at St. Joseph's Hospital. So that's just kind of an overview of my practice and what to expect. The only time I'm definitely in the operating room from the very beginning to the very end would be at Scottsdale. While at St. Joe's, that may be the case of a very inexperienced resident who's just starting out, or other circumstances, but I would not assume that to be the case. Additionally, in terms of technique, I showed some pictures of the stereotactic frame. I also use a surgical robot that I helped develop in terms of just basically positioning the direction to place the electrode. So I place the electrode, but instead of having a frame that we see, I think right here, these are the stereotactic frames that are used for DBS. Instead of setting manually, these are little numbers etched into the frame. Instead of setting all these manually, over the past several years, we've had an increase development in the technologies with surgical robotics. And the robot's not actually like doing things, it's just kind of aiming. And then I use that as my aiming device rather than this platform that you see in this image. This is kind of a side point, but it's important just a lot of this is part of the informed consent process, is understanding risks of the operation. This is kind of a disclaimer. So all of the DBS systems that are currently on the market are compatible with MRI scans under certain conditions. So to understand why this matters, you can take a step back. For example, back in the day, if you had a heart pacemaker, that was it. You couldn't get an MRI for the rest of your life. Veterans who have shrapnel, they can't get MRIs. So we know that there's certain implants in the body that make an individual ineligible for an MRI scan. Why would you need an MRI? Say if you had hip issues, back issues, knee problems, and your doctor wanted to evaluate that with an MRI scan. Then they order an MRI. They can't get an MRI. Usually a CT scan is sufficient. But there's a history of medical procedures rendering patients ineligible for MRI. Now, a lot of work has been done in the deep brain stimulation products to show the safety of these devices in the MR scanner. Now, there are stipulations to that. So when the FDA agreed that it's safe to get an MRI with DBS systems implanted, there are certain conditions that have to be met. Basically, there's about 8 circuits on each side of the brain that have to all be intact in order to get an MRI. You don't need all of those 8 circuits, that's 16 circuits total. You don't need all 16 of these to be functional in order to have effective DBS therapy. But if you want to get an MRI, you can't have any short circuits, open circuits, basically can't have a dysfunctional circuitry in the DBS system. And on rare occasion, at the end of the operation, there'll be a circuit problem that, in my experience and my opinion, does not I cannot justify chasing that problem down. That basically would be where on the second stage of the operation, we're putting the battery and I discover that the electrode that goes in the brain has a faulty circuit. And in my judgment, it would not be safe or prudent to redo the first part of the operation to chase that circuit. There's a number of reasons for that. Sometimes these abnormalities that we measure at the time of implant go away the day after surgery. Also, there's a risk of a complication of the brain if I read it. Suffice it to say, everything goes well. I come out and talk to your family and say, hey, everything went great. But from what I can tell at this moment, he may not be able to get an MRI. And this is how I cover myself, because sometimes I just need that elbow room because it's not absolute MRI compatibility. I know this slide can be a bit confusing, and basically, if this were to occur to you, I'd explain it further. But this is my disclaimer and my out saying that I don't guarantee that you can get an MRI after this operation, even though all the devices are approved for MRI. The issue is that it's under certain conditions, and usually those conditions are met, but sometimes they're not. There are 3 devices that are on the market: Medtronic, Boston Scientific, and Abbott. They're all effective, they all work, and the surgical procedure is pretty equivalent with all 3. It's between you and your neurologist, really, which one you go with. And then probably most importantly, risks of surgery. I do a lot of these operations. You're in good hands. I have a lot of experience. I'm very attentive. And this really is the right therapy for many individuals. And that's been well defined, especially with Parkinson's. Essential tremor is pretty evident. If your tremor is bothering you and it's the right kind of tremor, benign familial essential tremor, this will help. But I don't guarantee surgery. And that's very important to realize. I can't offer any guarantees. And in terms of complications, keep in mind that even with low rates of complication, they will happen again in my practice, and they can happen to you. And that's what you acknowledge when you send the consent forms. So the first one I include here, the big bad brain bleed. That's something that could make you permanently and significantly worse after surgery than you were before surgery. It's like a stroke. It could require going back to surgery and taking out the clot. That's rare. And what's really important here is that if you're taking any blood thinners, prescription medications, aspirin, it's important that you stop those before surgery. And the longer you can be off of them, the better. However, there are risks of being off these medications, and you need to weigh those risks, preferably with your primary care doctor, with your cardiologist, to make sure it's safe for you to be off those medications. But being on those medications increases the risk of surgery. And in the case of the brain, that could be a stroke. So when I say less than 1%, those big bad brain bleeds, the ones that cause permanent significant worsening, I'll see that maybe once a year. I'm treating maybe 150, 170 new patients a year. So I see this on an annual basis. And typically there's a lot of recovery, a lot of improvement, but it can really slow down the recovery, and it could be permanent. So that I put at the top. The next one is infection, right? There's bugs that we have on our skin, all of us have on our skin right now, that if we put it underneath our skin, it'll cause an infection. And if you have hardware, that infection may not be treatable with antibiotics alone. And in those circumstances, I actually have to remove the device from your body. That could mean removing everything, the two leads in the brain, the battery, all the hardware. Once we do that, we're basically pressing reset with infection, and your body with antibiotics will clear the infection. But sometimes, and the textbook basically says, if you have a hardware infection, the treatment is to remove the hardware. And that I see about once a year, I'm taking out part or all of the DBS system. Lead repositioning. So my goal is accuracy, precision, basically placing the electrode in a place that functionally is going to help you when the neurologist starts to turn it on. About once a year, there's an electrode that gets pulled out, or it turns out I thought it looked in a good place at the time of surgery, but based upon side effects or lack of benefit, or even post-operative imaging, it appears that we could do better, especially if you're not responding symptomatically to it. And this would result in having to go back to surgery and reposition where the electrode is in your brain. We'd use a new electrode, not the same electrode, but we'd basically revise that part of the operation. That happens about once a year. Hardware failure, we talked about the MRI scans and the circuits. Sometimes if you have a circuit problem and now your symptoms are no longer controlled because that circuit is not functional, then we'll go back and fix that problem. We'll replace the component or revise whatever connection is off. We can go back and fix the problem surgically, but each surgery carries a risk of infection, damage to the wires, and whatnot. So that's a trip back to the operating room. So if you see here, I've kind of highlighted 4 major risks that by virtue of being attentive and experienced, I can minimize these risks, but I can't make them zero. And you acknowledge that that could happen to you when you sign a consent. Now, when you've learned about the DBS therapy, there's this one thing you might have heard of called the honeymoon. And that's where now remember, the operation is done in 2 stages. We place the leads, and then 2 weeks later, we put the battery, 2 weeks plus or minus. And some patients, after the leads are placed, the brain part, they're walking better, they're not shaking. They actually feel like their symptoms are improved. And that's without the pacemaker implanted. And that's because of the trauma of surgery. The trauma of surgery, right at that node where the stimulation will eventually occur, can actually help with the symptoms, soften the symptoms. And that's by virtue of this some microscopic swelling, the microscopic trauma that occurs from surgery. Now, there's going to be swelling, not just at those little tips, and the tips are where you get the honeymoon, but you can also get swelling on the way down. And that swelling can cause side effects and cause problems. And that can include seizures, confusion. You can have speech problems, like an aphasia, word finding difficulties. And as the swelling goes down, those side effects go away. And sometimes I'll see blood in the brain along with the swelling. So when I say brain bleed up here and saying it's less than 1%, that's a specific category of brain bleed. You can have bruising, you can have blood in your brain. I probably see blood in the brain maybe once or twice a month doing DBS. And it's basically inconsequential, doesn't have any lasting effects. And in the elderly, it may slow down recovery a little bit, but I expect excellent recovery subsequent to that. So brain swelling, it happens to everybody. It becomes symptomatic in probably about 10 to 15%. And the way I think about this is, if you imagine undergoing a knee surgery, right? If afterwards you can't bend your knee like you could before, you're like, well, I expected that. I had knee surgery. You have pain in your knee, well, I had knee surgery. You may have some bruising, and you're like, well, that's because I had an operation. So that's all stuff that we're kind of familiar with our joints and whatnot. The brain doesn't feel as much pain. There's not really pain fibers in the brain. So oftentimes it's not a painful operation, but the same mechanism of surgery where you can get swelling, bruising, causes a different array of symptoms. That's the confusion, the seizure, potentially speech problems. And again, seizures are rare, but it's just important to be aware that this could be an experience, and it can be scary. So understanding where it's coming from, and if somebody has a seizure, for example, we may start seizure medication, but it's not like they have persistent seizures afterwards. We're able to control it, and eventually they'll stop the seizure medication. Death, coma, stroke, paralysis, something catastrophic, that risk is not zero. So anytime somebody goes to the hospital, something catastrophic could occur. I don't expect that, when I show up to take you to surgery, I'm not expecting that, but I'm aware that's just the nature of what I do. And it's important that you're aware that that risk exists. And it may not be during the operation. It may be, 4 weeks later, in such a way that had you not had the operation, this might not have happened. And because you had the operation, chain of events, they can have an indirect consequence on poor outcomes. And your health going into surgery really helps determine how well you tolerate an operation. Wrong device, you'll see at clinic, I'll basically go through an a la carte menu of what we do. And I think one of the important things is knowing, which of the 3 devices is planned, is it rechargeable or non-rechargeable. I try in clinic to make you familiar with the nomenclature we use to describe the operation so that when you sign your consent, you understand the terminology being used to describe the operation that you're consenting to. Wounds can break down. Wounds you may have trouble healing. It's rare in my experience. You can see this is a patient's ear over to the side. Their nose is blurred out. This is the forehead. So right behind the forehead, I have a half circle incision, and it's behind that incision, right in the middle, that I make the burr hole. This is about 2 weeks after surgery that I take this picture. And the hole that I make in the skull, there's a little bump right there that locks the wire in place. But this is the incision I make, this half circle, and I close with staples. And because I make a half circle away from the hardware, I try to keep all hardware away from the incision. That seems to help with wound healing. So it's rare that I see wound issues. Sometimes the staples will make the skin a little bit irritated when it's time to take the staples out. But this is what an incision looks like. I've already removed some of the staples at the back end of this half circle on the left, and you can see what they look like. I've described some of this narrative of Parkinson's disease with essential tremor. Again, proof is in the pudding. If you're shaking and it bothers you and a doctor calls it essential tremor, DBS can help stop the shaking. What is important is to be aware that after especially when you do both sides of the brain to treat both hands, when you turn the pacemaker on to stop the tremor on both sides, one side effect of stopping the tremor can be speech, meaning you feel your tongue's a little bit heavier, you feel like you sound drunk, you have to pay more attention to enunciate. So speech side effects and balance, where you feel a bit more off balance. Consider these side effects expected when you do both sides for essential tremor. We're usually able to there's a lot of strategies, and it doesn't bother everybody, it doesn't happen to everybody, but when you're consenting for surgery, it's very important to be aware of this side effect so that you're not surprised when the neurologist turns it on and you start noticing this and you think that something's wrong. Similarly, don't think of this as a cure. My goal for you is 85% improvement, not 100%. What that means is somebody who has a really high amplitude tremor, you shave off 85% of that tremor, and the remaining tremor may still mean that they can't do use small screwdrivers, do fine movements, and they may be dissatisfied if they can't do those specific activities. So having realistic expectations is very important in having a satisfactory outcome afterwards. So this basically covers the scope of what I do and what you can expect with surgery with me. And otherwise, we call this area restorative neurosurgery, where the goal is to restore function and give you control of your body back. Thanks for watching.